Hello, everyone, and welcome to another episode of Plastic Surgery Unfiltered, a podcast at the intersection of healthcare, business, and the beauty industry. I'm your host, Dr. Armando Davila, joined by my faithful co-host, Dr. David Turk.
Good morning.
Good morning. How are you?
Great.
Today's topic, weight loss isn't new, but the surgery gap is.
Yeah, this is a very interesting concept. I'm excited to talk about this.
Yeah. So the topic today for everyone is that, weight loss has obviously occurred for
probably forever.
Yeah. I'm not sure if the cave people were really concerned about it, but
probably not.
Probably not. But I want to go back essentially to the 80s and 90s and really talk about significant weight loss with the invention of bariatric surgery.
Right.
And how the concept of losing a significant amount of body mass isn't new, but that for some people it's feeling new, and that a lot of surgeons aren't really ready for the GLP-1 weight loss population.
Yeah, I think that I think it's easy for us to forget given our experience. Obviously Pittsburgh has been a major center of innovation when it comes to surgery after significant weight loss. And so I think given our experience in the city here, that we kind of forget that not everybody has done a lot of these cases.
Correct.
And so with this deluge of new weight loss patients, given the new technology, I think there's a lot to unpack here.
Yeah. I think that you start to really see this when, in particular extremity surgery, like, brachioplasty, thighplasty, and some other of these surgeries that don't really present as significant in the non-weight loss population, right? The sort of standard mommy makeover and things. And so you see when surgeons don't really comfortable with those, it really shows that they're not really comfortable with the weight loss population as a whole.
Yeah, absolutely.
And but it doesn't just apply to those two surgeries. I mean,
sure.
Well,
I think it's important to kind of quantify what is new and what is not new.
Yeah, let's do that. What feels new and what's a trend and what's kind of evolving?
I mean, just like for some general perspective, right? For patients that were significantly overweight, that were obese for a long time. So what we knew is that for sure, just telling people to change their habits, diet and exercise didn't work for 98 or 99% of people.
Sure.
And so for those patients that were significantly overweight, really the only strategy for them to get down to a normal weight was bariatric surgery. Right. And so there were a variety of different procedures that were advocated for at different points. They all had kind of their advantages and disadvantages. I think probably the most popular now is something like a sleeve gastrectomy, where part of the stomach is removed. And there's some restrictive component, but probably also a significant hormonal component to that as well. And most patients will lose a significant amount of the excess weight, at least I'd say like half of the excess weight that they have.
Yeah, absolutely. And they grade it depending on your success based off of the thing. And I think that one of the, people would, even back then were like, we're seeing this again now. Oh, this is cheating. Oh, you are taking a shortcut, right. Or you are this, right? And none of that's true, right?
It's ridiculous, right? I mean, obviously both of us are into food,
yeah.
Right? And so I've done a lot of reading and a lot of research on the history of food and food science in this country, and a lot of the food that that's available now is specifically designed to make you eat as much as possible.
It is purposefully addictive. It was designed that way, and so you are fighting a losing battle because behind the scenes they have chemically created the food to addict you to the food and for you to eat more.
Right. So your average American consumer is just constantly exposed to this, and so it's not surprising that many Americans are overweight. Now, obviously, there's different classes of being overweight, right? And it depends on how you stratify it, right? Like different BMI levels, whether you're overweight, obese, morbidly obese, et cetera. And different people probably now, given the variety of options for weight loss, are better candidates for one thing or another. But like we said, at one point, really the only thing we had to offer people was bariatric surgery.
Yeah, and I mean, one thing that we don't know, and we learned through bariatric surgery, number one, in order to undergo bariatric surgery, you had to undergo psychological assessment, like physical assessment. You had to demonstrate a pattern of weight loss even before your bariatric surgery because it was risky. You could die.
And I think even more significant than that is once insurance started covering bariatric surgery, you had to be pretty significantly morbidly obese before they would cover it.
Sure.
which I think produced a specific kind of weight loss patient.
Right. And so there was a lot of weight loss there. And we'll get back to that, I think, in a second.
Yep.
But my point with that was that this wasn't an easy process for people. And as we learned, we thought it was just a restrictive component, that by simply making the stomach smaller, that's what solved the problem. But we learned that there was also a hormonal component that was affecting it. And to talk about the addictive nature of medicine, of our foods,
right,
we don't really know how those things they put in the food are affecting our overall hormonal levels, our gut health, all that sort of stuff. There's a lot of science and pseudoscience associated with it, and there's almost certainly something that is happening.
Sure.
Right? Like the big one right now I keep bringing up on the podcast is the colon cancer thing.
Right.
There's obviously something that has happened with the food.
Oh, sure. I mean, there's way more young people getting colon cancer now than there used to be.
And so there has to be something that's happening at a more global systemic level. And so it finally feels like with GLP-1s, we have a tool to fight back. Right.
I think the term GLP-1 gets thrown around, but maybe explain what those medications are.
Me?
Yeah.
Oh, sure. I mean, GLP-1s are essentially a form of peptide, right? So they have a certain set of protein or amino acid bases, and they act on receptors within the body. They have to be a certain maximum length in order to be classified as a peptide. And they can act on certain receptors throughout the body. And so when you start to see things like Ozempic or which is semaglutide, right? It has single receptor action. And then you have tirzepatide, which has dual receptor action. And now you have retatrutide, which is going to have triple receptor action and potentially 4 and 5 receptor action. We don't know the future of this. Right. But these are receptors that have been identified to essentially change food habits, right, insulin release, all sorts of things, right?
And initially, these medications were intended for diabetics to improve their glucose control. But what they found was that these patients were showing significant amounts of weight loss, and so then they got their approvals for weight loss.
Correct. And they're not new medications. Again, also around since the 90s.
Right. And what's interesting was I think a lot of people thought that, for example, things like semaglutide worked primarily by decreasing gastric motility, so you felt full faster, right? Mm-hmm. Kind of the original proposed mechanism of a lot of the bariatric surgeries. But as it turns out, there's been ongoing research that showed that people that are on things like the GLP meds have a much lower rate of, let's say, death from opioid overdoses.
Correct.
And addiction and things like that. And so there are clearly much deeper processes that it is affecting beyond just decreased gastric motility.
Exactly. And you're seeing this through decreased consumption of alcohol and other things where the addictive potential or the central receptors in the central nervous system that have GLP-1 receptors are being affected. Right. There's actually a study that just got released, I think yesterday, that's showing that the cardiac protective effects of GLP-1s are happening prior to the weight loss. So you're already seeing a reduction in total cardiac risk even before you've lost the weight within 4 to 6 weeks of the initial effect.
Which I think, to your point earlier, that, these engineered foods are probably doing a lot more to your body than most people would understand.
Correct. But it also is an issue because GLP-1s are seemingly less targeted and more, I call them dirty drugs.
Right.
Dirty drugs are things that don't absolutely target a certain location, and so they can have unintended side effects outside of the system.
Sure.
And there's known ones, like, for example, the risk of medullary thyroid cancer,
pancreatitis, the issues with the eyes and things like that.
And so, everyone's like now, oh my God, these things are new, like these things aren't safe. But again, GLP-1s have been around for decades. Those are known. And the biggest problem is that people now are getting GLP-1s outside of their physician direction. And so you don't know if it's partly because the pharmacy.
Is it the actual medication? Is it something else that's in there?
Yeah.
This kind of gets back to like one of our previous conversations about the FDA and peptides and everything else. And hopefully people can start to see why this is so important and why being comprehensive about your care is so important.
Sure. And so, none of this is new, I think.
No.
And
I think it's not new in the sense that these medications have been around for a while. But I think what we're seeing now and I kind of like to describe it is it's almost this new class of weight loss patient.
Sure.
Right. And there were some of these people that existed before, but I think it's the volume. And like you mentioned, even in the title of the podcast, the gap that's starting to exist.
Yeah, I think the GLP-1s didn't like change the problem. They've just scaled it. They've just exposed
100%.
it. And so this is something that was a very niche topic, a very specific group of plastic surgeons or aesthetic surgeons or even academic or reconstructive surgeons targeted this, but now it's exploded in scale. And
well, I think, like you mentioned earlier, the access to bariatric surgery was quite limited.
Mm-hmm.
And obviously you had to go through an entire process of being vetted to be appropriate for surgery, get ready for surgery. Then you actually have to have surgery, which means that a surgeon has to bring you to the operating room and do that thing, which, that's a big undertaking. And so the number of those patients was relatively small. But, I think your classic, we would call them massive weight loss patient, is someone that you think of as having 100, 200 pound weight loss, these really significant weight loss with just tons of loose hanging skin. Mm-hmm. So, I'd say that was kind of the original class of what we would call weight loss patients. Then, of course, we all know, and I think most plastic surgeons in their practice are familiar with taking care of, I would call them more the mommy makeover class of mm-hmm. patients, right? People that have had children or had some modest weight loss. I don't know, 10, 20, 30 pounds, something like that. But now we have the GLP class of weight loss patients, these intermediate patients, where, they may not have had 100-pound weight loss, but they had more than 30-pound weight loss or something like that. And so you do have considerable skin laxity, and maybe it's not to the degree of these original massive weight loss bariatric patients, but because you don't have to go through the vetting process and have surgery and all that stuff, there are orders of magnitude more of them.
Correct.
And this is where the issues, I think, are.
And you've been fighting me on this, but I've doubled down. Okay, to me, I've created my own classification system for this, and I know you want to validate it, and we can take it to the research level if you'd like. But to me, when you have that original population, the standard quote mommy makeover, mm-hmm. the person who's struggling with a little bit of weight loss, like the person who's in that 20, 30 pound fluctuation, that's class 1 for me.
Yeah.
Anybody in that 100 plus the 3-digit, bariatric style classic patient, that's a class 4 or above for me.
Yeah.
And then you have these two classes, class 2 and class 3, which occupy a lot of these GLP-1s. And what starts to differentiate is when you have to move essentially from these minimally invasive or less invasive procedures into sort of more advanced versions of these procedures. So, again, we use a term tummy tuck, and that's a very global thing. But the kind of tummy tuck that you do or abdominoplasty you do for a class 1 is very different than a class 4.
They're almost not the same operation.
They're just not this operation at all. And then in between, there's variations that you take from a class 4 patient and you introduce into these class 2 and 3s. And they're very hybrid, very nuanced procedures. And many, many surgeons just don't know how to bridge that gap.
Right. Because I think you're exactly right. I think that it's hard to figure out who's in the intermediate, right? Because it's like a lot of things, it when you see it. If someone has had minimal weight loss, they have a little muscle separation, you're like, this person is clearly a good candidate for a classic tummy tuck, mommy makeover, whatever. When someone has 25 extra pounds of skin hanging off, that they are in that traditional weight loss class, that they're going to need kind of the most extreme version of these procedures. But you're exactly right. And honestly, sometimes that's just having a conversation with the patient to understand what their goals are, what their concerns are, and matching the right level of procedure to their goals and concerns.
Right. And I think that one thing that's sort of startling for most people who are now in this new class is that they believe themselves to be sort of in this class 1 stage, but they've lost enough weight. Like maybe these are people who have struggled with their weight. They're used to having lost 20 pounds. They're used to having lost 30 pounds, and they've always seen themselves in that lens. Now they get to 70-pound weight loss, and they're struggling with the idea that they need these very invasive procedures, and they are like
a bigger surgery. 100%.
And they will sometimes then go to these surgeons who are saying, "Oh, I'm going to treat you like a class 1."
And then they get a suboptimal result.
A very suboptimal result.
Right.
And then that even happens to us where we may say, "Okay, I think they're a class 3, but I'm going to treat them like a class 4 after discussion," and then they have still a suboptimal result, and then you have to kind of upgrade them up the path. And this is tough because these things are not without sequelae. They're not without scars. They're not without recovery.
Well, I think that's probably in my experience, the couple of things that people are the most concerned about are the scars and the recovery, right? And so, I think that's a really important point that people need to understand, is that there's a limit to how much we can make things minimally invasive or hide things like scars. If there's a significant amount of skin laxity, first of all, anyone that tells you that any kind of non-surgical treatment is going to work is completely full of crap.
Well, can you specify that? Because they do something. It's just...
Well, I mean, if you have rolls of skin hanging off, some of these like skin tightening technologies are not going to produce like a significant result.
Right, because there's literally no product on zero. Just to be clear, there are zero products on the market that tighten your skin, that shrink wrap your skin like a heat gun.
That decrease the surface
area of your skin. None. Not a single one. And if you press the reps, if you press the companies, they will absolutely admit to that. And if they do advertise that, and if you think about what it looks like when you take a package of shrink wrap and you heat it up and it gets all crinkly, that is what's going to happen to your skin. Mm-hmm. And so that doesn't look nice. You can have products which create subdermal tissue retraction, which make the skin stick better.
That's how I kind of describe like shrink wrapping.
Yeah, it makes it stick to the product, but it will inadvertently make it look wrinkled in an extent. Right. And so the only way to remove skin from your body is to fundamentally cut it out.
Right. Which of course results in a scar. Mm-hmm. And I think that people need to understand that that's the trade-off, mm-hmm. right? And I would say that once you have the conversation with people and they understand what the benefit of doing that is, that most patients are very amenable to that.
I would say.
I mean, not everybody.
Not everybody. I think that
that's probably also where I think a lot of people get in trouble, right? If you haven't treated these patients, and even if you haven't made these mistakes, you may say, oh, I can apply my traditional techniques to these patients with more significant weight loss, and the result will be okay, to try and limit things like scars. And then you do that, and the result is not okay.
Correct. I think, when we train in residency, we often talk about adherence zones and areas of firm fascial to skin adherence. Mm-hmm. I think about how when you do a tummy tuck in a mommy makeover or in a patient who's in the 20-pound weight loss, you pull down that tummy and the breast position doesn't fundamentally change, right?
Right.
If you take a patient who has lost 100 pounds and you pull down that abdomen, the breasts come down with it.
A little bit, yeah.
They slide down.
Mm-hmm.
And the more weight loss, the more they slide down. The adherence zones have been sort of lost to a certain extent. And if you do not understand, if you do not have experience of understanding these patterns of laxity, understanding staging, understanding how one surgery is going to affect another area, because you've never been that kind of surgeon, right, you're going to have a lot of trouble here.
But I think you mentioned something that I think is also really important, is staging, right? I think that it depends on, you have to customize a plan for every patient. And sometimes that's one procedure, sometimes it's two, sometimes it's three. It really depends on globally how much laxity they have, the areas of concern. We really try and limit, surgery to surgery that's appropriate as an outpatient. Mm-hmm. We don't want to do 12-hour surgeries where people need to be in the hospital, increased risk of things like, significant blood loss, needing transfusions, blood clots, all these things. Our predecessors have gone down that road.
Yeah, and we know that it doesn't end well.
It doesn't end well. It's too much surgery for people to heal. Mm-hmm. And so, I think a lot of people come in and are surprised when you tell them, this is probably 3 operations over 2 years. Mm-hmm. And they're like, really? All of this stuff matters.
Yes, and then they end up somewhere with a surgeon who's like, oh yeah, I can either all do it at once or I'm just going to solve this with one surgery.
And then it doesn't work.
It doesn't work, right?
Well, it doesn't. It just doesn't get them what they were hoping for.
Perhaps. And again, if people are really focused, and we do that all the time, they come in, there's a lot of weight loss, and they're like, but this is really the only area that bothers me. Okay, we're not going to, we're not going to
sell you, like if your abdomen's the only thing that bothers you, try and sell you your thighs and your arms and your breasts and everything else.
If it doesn't bother you, then it doesn't bother us, right? But at the same time, the understanding and the counseling we give to make them understand that if you really are going to focus on your abdomen and you've had 70 pounds of weight loss, there is going to be a transition zone where your tummy is tight and your back is loose, right, and your butt is loose. And it is, we did not make your back loose.
And what's funny is like, how many times have you seen patients when they're like, I understand that, that's fine. We do the first surgery. And then 6 months later, they come in and they're like, you know what? You were right. Let's do stage 2.
Stage 2, right? And so, and again, we are here to meet people where they are and do it at their pace. But like, Pittsburgh and our training here and our experience with these patients have really prepared us for this. And this is not your run of the mill tummy tuck. This is not your run of mill breast lift. These are. It looks from the surface. Like on the surface, right, a parenchymal reshaping or breast reshaping mastopexy looks exactly the same to the person.
Well, because the end result looks essentially like a normal breast.
Correct.
But what they don't appreciate is that, what needed to happen to get from that more significant deformity that was caused by the weight gain and weight loss is different than just doing your standard breast lift.
Mm-hmm. And without training them to be plastic surgeons, it's hard to explain that.
Right.
And let's face it, some plastic surgeons don't even
understand the difference.
Yeah,
absolutely.
And so I think this is also happening with face surgery, right? What's going on there? I mean,
Ozempic face has been around, that term has been around for several years now. Mm-hmm. And I mean, I still am not sure whether patients that are on GLP-1s have more significant tissue atrophy and, tissue laxity than ones that lost weight in other ways. Personally, I don't really feel like it.
Yeah, I mean, there's that idea that there's some accelerated muscle mass loss with GLPs, right, but it's not bearing out. I think they just finished an MRI study on this, showing that it's...
And I'm not sure that would really affect the face anyway, regardless. I mean... but the point is that I think a lot of people that normally, traditionally, if they hadn't lost weight, wouldn't have pursued facial rejuvenation, things like facelifts. But with the weight loss, they see it. And so the same things that happen in the body happen in the face. You lose the fat, and so now the skin isn't as filled, and so it sags, essentially, mm-hmm, right? So we see neck laxity, jowling, heavier folds, all of those things.
Sure. And perhaps maybe there is a structural component to the skin that has been sort of lost or stretched. It's sort of unclear. The natural mechanisms of aging don't typically involve stretch per se. They generally involve ligamentous laxity, volume loss
of collagen,
and repositioning or
right,
position issues.
Right.
But you don't really have that much, quote, excess skin. But with weight loss patients, I am seeing more patients that do have fundamentally excess skin. So when I'm doing these cases, I'm like, wow, I'm removing more skin than I ever have, even though, that's not necessarily what we're targeting. And so, does that make sense?
Yeah, absolutely.
We're still modifying this. And so, I think that there's, I guess the question is, do you think there's surgeons out there offering procedures that they shouldn't be for these patients?
Probably. I mean, I think if you have no experience with patients that have had significant weight loss, and again, maybe now as GLPs have become more common, even in training, people are seeing more of this, and so more surgeons are better trained. But I think some of the older surgeons that didn't really deal with these more significant weight loss patients, I mean, I hate to say it, but we've seen it in our office. Mm-hmm. We've seen secondary cases where they got the class 1 surgery for a class 3 patient, and they didn't have a great result, and they're not happy about it.
Yeah.
And I think, I'm not saying that was necessarily the wrong procedure, but, again, everything in plastic surgery is about setting expectations. And so if this is what the procedure you're going to do, you just have to let the patient know that this is the result that they can expect.
Sure. And I think the patients don't know what they don't know either.
Sure.
So they're going to a lot of surgeons, and they're basically saying, well, yeah, we just do this tummy tuck. And again, to the patient, a tummy tuck is a tummy tuck is a tummy tuck.
Right.
And so it's tough to make sure that you are really informed as a patient and
sure,
understanding.
And of course, as with anything, there's of course differences of opinion even among surgeons.
Sure.
Some people, prefer this surgery or this procedure to that procedure, mm-hmm, or feel that this works better than that. And so, I mean, even as a surgeon, it's sometimes confusing as to what the best course of action is. And so I'm sure to patients, it's even more confusing.
Oh, absolutely. And especially when you introduce minimally invasive devices and radiofrequency devices, it's like, can we get away? Because again, I can always add a scar. We can't take it away.
Sure.
So I tend to hedge sometimes on the side of less scar and see if we can get away with something. But then, sometimes it's not, the body doesn't respond.
But again, the gap between happiness and unhappiness is just having that conversation and setting the expectation. Do you want to, take that risk? Do you want to try this? Do you want to do this? Do you care about the scar? I mean, and it's sort of up to the individual person.
Yeah.
And that's why that conversation is so very important.
Yeah, I just think these have to end up being really customized.
Yeah.
I mean, so to me, it's this is not a new problem. It's been around for a while, and it's either it's new to some people,
Right.
and I hope that they kind of learn and get to catch up. But it always reminds me, whenever you're starting off, or whenever you're a plastic surgeon or any type of surgeon, when you're trying something new, you want to start with cases that are sort of like
relatively straightforward.
Relatively straightforward. And so if you've been typically doing class 1 cases your whole life, or your whole career, you're just kind of starting off with class 1s, then you really want to start just moving into those class 2s, these 40 to 60 pound weight loss people, that could take a hybrid approach, some liposuction, some minimally invasive, and then work your way up. If you normally tackle, 30 pound weight loss and 150 pound comes in the door and you've never done one, you should work your way up to that.
Yeah, absolutely. Absolutely.
So, and we do the same, right? When we, especially like with eye surgery, right? Like if I have a patient that has a lot of blepharoptosis and like asymmetry, and, I send them to the eye specialist, right?
Absolutely. Absolutely.
And so, everyone would be wise to kind of think about it that way.
100%.
Okay. Well, thank you everyone for joining us again. We're going to be taking, requests, I think, coming up. So if you have a topic that you really want to hear about on the podcast, you can leave it in any kind of comments or on Instagram or on the podcast portal. And so we'd love to answer your questions. Thank you.